Good afternoon. So today's topic is kind of the second part of our stroke series, where we're going to talk more about the causes of stroke and what we can do to prevent them once we've figured out what the most likely etiology is. And we'll try and take you into basically how a neurologist would approach things, kind of into the mind of a neurologist, which is a frightening place to be, but there's a little logic to our process. So just a couple of epidemiology points just to impress upon you the significant impact of stroke. There's 800,000 strokes a year in the United States, which amounts to about a 1 in 4 lifetime prevalence of having a stroke at some point. Once you've had a stroke, the risk of death is 20% or 1 in 5 at 30 days, 5th leading cause of death. This leading cause of disability, as most of you know, and then many are left unable to resume the same vocation they were having or to require assistance and be unable to care for themselves at home. So really a huge topic. The cause of stroke, it's grouped into both ischemic and hemorrhagic. We're just talking about ischemic strokes, which occur or account for about 85% of the strokes that we see, which is actually different in other areas of the world. It's a lot higher incidence of hemorrhagic stroke, and that gets to the genetics, especially the Eastern Asian population, for example. So that comes into play a little bit later. So just some basic review, how do we recognize a stroke? What is a stroke symptom? And for those of you in the ER are trying to determine if we've got a TPA candidate or not, that's easier said than done. Patients don't come out and say, I've got dysarthria or I've got half of my vision gone in both eyes. They say something's funny about my vision, or I can't talk right, and again, you may be getting this secondhand from family. But you look for symptoms that affect one side of the body, numbness or weakness, not just in one arm, but in an arm and a leg, or a face and an arm. You look for ataxia that might be gait. Sometimes that could be one-sided as well. Speech is important to distinguish. Is it a dysarthria or a slurring or imprecise production of speech, or is it a language problem or aphasia, which is I can't come up with the right words, they're nonsensical words, or a disfluency in speech. And then things that would raise a red flag as to, well, maybe this might not be a stroke, would be things like isolated vertigo without weakness, or double vision without any other symptoms of dysarthria or weakness or numbness. Progression of symptoms from one type to another, or if you have recurrent stereotype spells, it's much less likely to be a stroke, maybe more likely to be a seizure or something else along those lines. Stroke usually doesn't cause confusion or loss of consciousness either. So that would be something that conceivably could be part of a stroke, or, can be confused for aphasia, for example. But for the most part, stroke affects one side of the brain, and it should not generally affect your consciousness. The differential, just kind of a list. It's not exhaustive, but kind of hits the highlights of a number of things that can mimic stroke. The things I think that are most important to remember, especially for transient focal neurological symptoms, are complicated migraine auras, which can cause numbness or speech difficulty on occasion, or vision trouble. Seizure, which may be only evident based on the after effect or the postictal deficit, so you could have weakness that might mimic a stroke. And then in psychogenic etiologies, not uncommon, unfortunately. And I'd say if you remember those three things, you've got 95% of the differential, or the patients that come in. It's got to be, TIA or stroke, and then one of those additional three things. Everything else is usually you're able to sort that out, and usually doesn't cause transient TIA-like symptoms. Just a comment on the changing definition of a TIA. So officially, you'll still see it as a reversible neurological deficit that improves within 24 hours. But realistically, If you've had your deficit more than 30 minutes to an hour, you probably actually have some tissue damage. And very often we will scan somebody who's had a TIA. They feel like everything is better, but yet we can still see just a little bit of ischemia on the MRI. And so technically that's a stroke. And really, when we talk about TIA, the new definition would involve, transient symptoms, but without any evidence of actual tissue injury on MRI or retinal exam. So something that really hasn't left any definite mark or objective injury, which is difficult because that means your TIAs are entirely clinical and subjective. So you're relying on the patient and the description. You don't have anything that's going to confirm that TIA aspect for you. So one of the focuses will be on the mechanisms of stroke, and we'll get into some more details of that. And officially, the three mechanisms are thrombosis, meaning you can have a clot that forms in a vessel. You can have embolism, which is a clot that forms somewhere else and then travels along the bloodstream and eventually occludes a blood vessel. Or hypoperfusion, which would be a loss of autoregulation or a lack of blood flow to the extent where we're getting tissue hypoxia. The hypoperfusion is a much less common cause of focal stroke for sure. We're going to see it in those patients after cardiac arrest with anoxic injury and such. But, that really is a different animal than what we're dealing with today. So of the mechanisms, the most common mechanisms, kind of the three things that I would keep in mind are, is it a large vessel process? So this could be middle cerebral artery, anterior cerebral artery, posterior cerebral artery, all anterior circulation. Well, I should say the first two are anterior, and then posterior would be PCA and vertebrobasilar system. But we're dealing with a kind of a major artery thrombosis, and we're going to get big symptoms and big syndromes as a result of that. And then there's small vessel or lacunar syndrome. So these are where we're going to see typically measured on imaging as a 1 to 2 centimeter, typically 1.5 centimeters is the upper limits, where you've got a small area of tissue involved, and you're going to get a different symptom pattern from that. But it also reflects a different cause for the stroke. So we're dealing with a very different mechanism in a small vessel infarction as opposed to a large vessel infarction. And then the third, and also very important, is cardioembolism. So something that forms in the heart or a valve or the aortic arch is sometimes included in that, and we can get atheroma that will travel from the heart and then lodge in a blood vessel, and we'll see how that the brain is the first stop basically after the aorta comes off. But this kind of just clarifies, I guess, the major distribution. So the blue is the anterior cerebral artery. Middle cerebral artery encompasses a large area, which is why we're going to see predominantly MCA strokes. And then if you look at the just penetrating vessels, this is where we would see the small vessel or lacunar infarctions. And again, you're going to get that with entities that will cause small vessel disease, and we'll get into that. This just is a better look at the posterior circulation. Again, if the vertebral arteries come directly off the subclavians, off the arch, and will join to form the basilar, and then we have the posterior cerebral artery on this side and on this side, and that goes to your occipital lobes, but would also encompass a large artery type of issue. Whereas the smaller penetrators, as you can see on the pons, those are typically going to cause your small vessel or lacunar infarctions. All right. So this would be a large or small vessel. Any takers? So here's the area of infarction, right? The darker area. Yeah, so large or small? Large. So this is basically encompassing most of the MCA distribution. And this is probably in the subacute phase. So on CT, you really are not going to see much early on. In addition to the fact that this whole area is dark, you can see it's swollen. You can't see the sulci as well as you can on the opposite side. We've got compression of the lateral ventricle here, some shift of the midline. So we've got a big MCA stroke over here. And again, that could be an occlusion of the middle cerebral artery, which could occur within the vessel. But very often, the first thing we think of with this is a cardioembolic stroke. So unfortunately, AFib is going to give you your big distribution strokes. So large artery syndromes, again, it could be an intrinsic lesion, meaning of a lesion within the vessel. We've got a plaque, and then we develop an acute thrombosis as the plaque ruptures or due to the irregularity of the plaque. You certainly can have vasoconstriction. Very rare, we'll see it, sometimes as a complication of subarachnoid hemorrhage will cause vessel spasm, primary vasculitis or autoimmune diseases, but that's extremely uncommon compared to what we normally see. We will see arterial dissection. So this is typically in the carotid or the vertebral vessels, and that's more of a traumatic injury. And we'll have some diagrams of what that looks like. And then again, uncommon causes, temporal arteritis are the causes of arteritis, fibromuscular dysplasia, which is kind of a new category, but can be seen more often in young people. And then always remember, when you see a lesion, say we see a carotid artery that's narrowed, you have to make sure that there's actually symptoms referable to that distribution. So it makes a big difference if we would call it a symptomatic lesion or if we just happened upon an asymptomatic lesion. The risk is entirely different for those two things. Again, just another list of some of the things that can cause large artery syndrome. Some of it actually involves some small vessel like moya. And we'll move on to small vessel. So this is the lacunar syndromes. And as you can see, so this is a diffusion weighted image on MRI. Diffusion shows the acute ischemia. So within minutes after a vessel is occluded, we'll see not only lack of blood flow, but we start to get cytotoxic edema. So the fluid starts to become intracellular and the diffusion signal is restricted. And so that's what we call an abnormality, restricted diffusion area, but it happens very soon after a stroke. And then it also goes away after about 10 to 14 days. So we can differentiate from chronic disease. So down here, this is the FLAIR image. We can see the what looks like the acute one because it's acute on diffusion, but these other areas also would qualify as small vessel infarctions, but because they don't show up on the diffusion image, we know that they're chronic. And so we can get a nice sense of what's new and what's old and what might be referable to the patient's clinical presentation. And again, just another look again at the small penetrating vessels, which are usually the culprits. And the typical syndromes, again, by definition, it's usually less than 1.5 centimeters. Again, it's deep structures of the brain. So basal ganglia, the thalamus, the brainstem, these are where all those penetrating little perforators go. And very often you can have a small infarction that doesn't cause any symptoms. So people can develop a lot of silent disease, especially if it comes on very gradually. And you'll see lots of old strokes, so to speak, but they may not even cause any symptoms at all. And these are, of course, much less likely to be an embolic issue because, again, embolus is going to be a clot. It's usually going to be larger than what will sneak through into a small vessel, but not entirely. You can get some very small microemboli, or you'll see an embolic pattern, and sometimes there's a little bit of small vessel occlusions and some larger ones. And sometimes you can just tell by the patient's presentation that it's going to be a small vessel problem. First of all, you get a little history and they've got diabetes and smoking and hyperlipidemia and hypertension. And so you know they're at risk. And then they come in with weakness of one side, but without any sensory accompaniment. So, and then sometimes if you hit it in just the right spot in the internal capsule, you can be hemiparetic. So it can be a major deficit, but yet their sensation's fine, their speech is fine. We don't have what we call cortical symptoms. So in the cortex, you've got, language and calculations and kind kind of sensory agnosia, things like that. So a lot more complex symptoms. But if we get down into the deep parts of the brain, we're talking about just the meat and potatoes. Is it motor? Is it sensory? Is it ataxia? And usually you'll see those things in isolation. So in the thalamus, we can get a pure sensory syndrome. Internal capsule is pure motor. You can get these syndromes in the brainstem that usually involve a combination of weakness and ataxia. And when you present with that, without even looking at an MRI, you know about where it is and what the mechanism is. And as I mentioned, the risk factors typically are those that cause small vessel disease, which is high blood pressure, diabetes, and smoking. And you'll hear me emphasize those repeatedly because those are the big three. And those are things we can do something about. Family history definitely plays a role. Some patients are just more prone to small vessel issues, but we haven't found a medicine to fix that yet. Cryptogenic stroke is just the term that's used when we really can't determine a definite cause. And so therefore, it's a little harder to know exactly how to approach the prevention. We'll go into a subset of that, which is the embolic stroke of unknown source or origin. And this is kind of typical of what you'd see with an embolic infarction. So number one, we've got a large vessel distribution. It's not the whole MCA. Again, this is diffusion, and it's the left middle cerebral artery territory, kind of a wedge shape, goes all the way out to the cortex. And we see it up here as well. But you can also see we've got a problem on the opposite side. So we've got an acute infarction there. We see them over here. We've got others in the posterior aspect. So we've got multiple distributions involved. Again, it's impossible or statistically impossible to have, both MCAs be symptomatic at the same time. So it's probably going to be an embolus that broke off and then showered, and we got different clots that land in different distributions. So even even if we haven't been able to confirm AFib, there's times when we know that that's got to be cardioembolic. Now, maybe it's due to a hypercoagulable state or a PFO or something else, but at least we know it's probably a heart-related issue, especially if you see it in a relatively young person without the classic risk factors. And if you look at the anatomy, we've got the aortic arch down here, and then the first stop basically is the right carotid artery, and if the flow usually actually falls more into the left cerebral circulation. So you're going to see a lot of left cerebral MCA syndromes. So you can just visualize the embolus moving its way up and then into the middle cerebral artery or carotid distribution. And very often isolated aphasia might be something you would see, and that's really perks our ears up for atrial fibrillation. So sometimes we can say we have a known cardiac source, which I don't know if we ever know 100%, but at least we know they have AFib, or we've discovered they have a thrombus within the ventricle. And then there's suggestive embolic sources. So maybe we do have a patent foraminal valley. PFO is that hole between the two atrial chambers. And anybody know what percentage of the general population has a PFO? Yeah. So 1 out of 4 patients is going to have this and not going to have any problem with it. And so whether it's truly the cause takes a little bit of work to sort that out. And some of that has to do with the characteristics of the PFO and some other factors, but that gets to be a challenge sometimes. All right, kind of like we mentioned, there's some things that suggest an embolic source, multiple distributions. If you have a big vessel that's cut off on angiography, you could also have risk factors for stroke or without actual having atrial fibrillation. So you can have a diseased atrium, and that will sometimes be enough to cause it. But unfortunately, that's hard to confirm, and we're looking more for more of a definitive source before we put some on anticoagulation. So it's a little more of a judgment call. Again, a known embolic source where we can say, yeah, that's pretty much exactly what's caused it. So they do have atrial fibrillation, they do have a thrombus, maybe they have endocarditis. Certainly if you've got a device in the heart like a left ventricular assist device or an LVAD. And then if you see something funny on echo. Maybe we got a papillary fibrillostoma or something that's attached to the valve. So there's a number of those where we will be relatively confident that that was the cause. So just another comment on the PFO. It's, we'll see it on echo, but it depends on, is it big? Was there a shunt? We need a bubble study to see it. So that's, when we do our echoes, we need to do that to be able to really assess whether there's something there. We're going to see it better on a TEE. And well, it's present in 25% of the general population. In strokes that we have not figured out a cause, the incidence is probably about 50%. So, we know that it plays a role, but we go anywhere from a minimal PFO with a tiny shunt or none to a gaping PFO that might have a floppy septal aneurysm, and there's other factors that would increase that risk. And you can say, well, why don't we just close them all up? If it's a puncture problem, they've had a stroke, let's close it. Well, putting even a percutaneous through catheterization device actually has a procedural complication and a risk of inducing atrial fibrillation of about 5%. So, it's not a benign procedure, and sometimes we might be defeating the purpose. If we close the small hole, but we induce atrial fibrillation, then obviously we haven't gained anything. But it's a judgment call, but usually you can have a sense that the high risk ones are reasonable to close, and then we'll work our way down, and some of them are difficult to discern. Long-term cardiac monitoring. So this is one of those things that you figure out as you go. There's a patient I had just today, came back roughly in his late 60s, presented a year ago with a stroke, although he had mentioned that a few months earlier he had numbness in his face that never quite went away. And so presumably there was an event there. 2 months later, had weakness on one side, and we were able to see small stroke on his MRI. And it was in a pattern where it really looked like, well, the symptom he had originally one side of the brain, and then this was on the opposite side of the brain. So right there, we're getting a little more interested in saying, boy, maybe this is cardioembolic. But yeah, we don't have the smoking gun and to say, okay, yeah, we should definitely slap you on Eliquis or warfarin. And did, a TEE, did a 30-day monitor, no AFib, TE looks good, is relatively few risk factors, and do our dual antiplatelet, and then go to statin and platelet monotherapy. Then he has another event 6 months later, and at that point we again are highly suspicious of an embolic source. He's got a small PFO, which we knew from the original TEE. And at that point, we empirically put him on Eliquis because we probably likely have something coming from the heart, although it's again not clear. And then he gets a monitor, an implantable monitor. So this is the loop recorders that goes just underneath the clavicle, and they will monitor, cardiac rhythms for up to 3 years, from what I'm told. 6 months after he has that in, he finally has his first episode of atrial fibrillation. So a year later, but it speaks to the need to monitor people longer than just 2 weeks, or sometimes even for a month in high-risk situations. And I think it really reflects the fact that very often we've got a sick atrium. And there's some factors that, is there stasis in the atrium? Is it fibrotic? There's other factors that you can look at. But clearly we can have embolus without actually having atrial fibrillation. And those patients need to be on anticoagulation. And the studies here, which back in 2014 were kind of the seminal studies that showed that, the longer we monitor, the more AFib we pick up on. And if we go, from a routine EKG in the ER, you might pick up 2 to 3% of patients with stroke have an atrial fibrillation. It goes up as you go longer, and in 30 days, you might pick up, 16%, depending on how you what you call AFib. Is it just 30 seconds or does it have to be longer? And the studies differed that way. But you go all the way out to 3 years and suddenly we're picking up 30% of those patients that have atrial fibrillation. And these are folks that were at least suspicious for an embolic source. So we're doing a lot more implantable cardiac monitors, at least in patients that were suspicious. And again, these would be the patients, an embolic source of unknown origin. It looks embolic, we just don't have a source. It's common, it affects maybe about 25% of the strokes we see. Oftentimes they don't have a lot of risk factors. They don't have major large artery disease or carotid disease. And typically there's no evidence of a structural cardiac cause or dissection or some other explanation for the stroke. All right, cervical arterial dissection. So this is kind of a separate category of stroke, but one of the causes you need to be aware of that will more commonly cause stroke in younger folks. I'm going to jump to the diagram here, but what a dissection is basically we have a tear in the inner lining, the intima of the artery, and then blood is forced in between the layers and begins to basically form a mass or a clot within that area, and what we would call a false lumen. So the blood goes in here, but in the process, we're starting to occlude the major artery on this side. Here's an angiographic picture of this where you have a characteristic, you can almost see the false lumen. If you follow it, it's got to be right in there. And we'll have this kind of beak appearance, and that's basically indicative of a dissection. So how does a dissection happen? Well, half of the time we don't know why, and so they can be spontaneous, but classically they're associated with trauma. So these are extracranial arteries, the carotid and the vertebrals. The vertebrals are tethered along the spine, and so with rapid neck manipulation or a car accident or roller coaster or and sometimes what seems to be minor trauma, we can see that. The good news is that they usually end up doing quite well. So while we see them in younger patients, there's good collateral flow. So you can sometimes occlude in a carotid and there's enough collateral circulation that we get by without any actual stroke. There usually is some pain associated with it, but unless you start asking about potential trauma, you're probably not going to get them to volunteer that history. Again, usually they do well outside of the acute situation. We'll go over some data in just a moment about whether it's better to just put them on aspirin versus anticoagulation. Basically, there's a trend toward improvement with being on anticoagulation just for 3 months, although there's several studies that don't show a lot of difference between the two. And the incidence of stroke is really uncommon. So it's less than 10%. So they're probably going to do well no matter what you put them on for the most part. But there may be a slight benefit to anticoagulation. So we'll move on to prevention. So now we think we figured out what the cause of the stroke was and how we're going to go about trying to reduce their risks so they don't have a further stroke. So the first thing we want to do is this is in the very acute stage. So they're in the hospital within the first 24, 48 hours. Do you want to slap them on a antihypertensive right away? And of course, I think all you know the answer to that is no. So early on, we want to let the blood pressure run high. And when I say high, it's up to 220 over 120. And that's the official American Stroke Association guidelines. And the thought is that if you reduce it, especially acutely, then you're going to decrease the perfusion to that stroke, and the area that's marginal is going to become an infarct then. And if you think about it, the brain realizes that there's ischemia, there's an autoregulation that raises the blood pressure. In fact, if you have a sizable stroke and your blood pressure is normal, I would question whether it's a stroke. So you almost always get a reactive hypertension. And so it's important to maintain perfusion in that area. And depending on the situation, we'll at least do it 24 hours, maybe up to 3 days. But acute hypertension is really not going to get us into trouble. Once it gets up into the 230s, et cetera, we'll start to treat it, of course. But other than that, we can generally let it go, and it'll go down on its own in the first 48 hours typically. We want to maintain blood sugars. Studies have shown that we do not recover as well if we've got persistent hyperglycemia. So that means we don't have to be perfect, but if we can keep it less than 150, that's a reasonable goal. The role for dual antiplatelet therapy gets a little bit complex, but the major thing to consider is if it's a relatively small stroke, meaning there's not a lot of risk for it to convert into a hemorrhage, then we can use dual antiplatelet therapy for the first 21 days, and we will get a modest risk of recurrence. And the highest risk of stroke occurrence is going to be within the first several days or the first 3 weeks in particular. If the stroke is larger, meaning it has a higher risk of turning into a hemorrhage, or if we have a bleeding complication, then we're going to want to just do single antiplatelet therapy. And there's a rare circumstance, typically with a intracranial stenosis of greater than 70%, that we might benefit from 90 days of dual antiplatelet therapy, or there's some cardiac indications where we'll need to be on dual. But for the most part, it's not felt to be effective long-term. And that is one of the points here in just a moment. But one question is, when do we start statins? Well, statins have been shown if we start them very early, we can get some, a small additional degree of benefit in terms of recovery. AFib, the knee-jerk reaction is to think, whoop, we need to get on anticoagulation right away. But again, when we've got a sizable stroke, that tissue is unstable, and there's a fairly high risk that we could get a hemorrhage into that area if we put some on anticoagulation early on. And the risk of a recurrent stroke from AFib is really quite low within the first week. So we can tolerate that, and usually, depending on the size of the stroke, wait up to 2 weeks if we need to. Typically, it's going to be 3 to 5 days, or maybe a week if it's a little bit larger. And if it's a TIA or a very small stroke, we really don't have to wait. So at that point, we could, and we're sure that this is the cause, we can go ahead and initiate anticoagulation. If they do have carotid disease, we want to get on top of that. If it's a really active high-grade stenosis, we want to get that fixed within a couple of weeks. Used to be we'd always wait 6 to 8 weeks after a stroke to optimize their surgical risk, but the risk of that is so high that a lot of people would have a stroke before they got to the operating table. So typically within a week or 2 weeks, and again, that's a judgment call just depending on the severity of the lesion. And then, down the road, once we figure out if the PFO is high risk, which is, boy, these are young patients, they look like an embolic source, it's not a lacunar, and the PFO itself looks like it's high grade, then those will be candidates. So the risk of recurrent stroke, after the acute phase is significant. 25% in the lifetime, as we mentioned. It depends on the studies, and they've changed a little bit over the years, but it used to be roughly a 10% risk in the first year. With the treatments, more recent epidemiological studies show it's probably closer to 5 to 7%, but still very significant. And then if you look at the all-cause mortality, which again, these folks likely have heart disease, they may have diabetes, they may be ill for other reasons, the overall mortality is pretty impressive. So up to 70% in the first year and more than 50% in 10 years. Risk of stroke after TIA is similar, so I would treat it the same way. In some respects, it's even slightly higher in some series. All right, what are the risk factors we can do something about? And again, we're talking more about your small vessel, lacunar syndromes, hypertension, diabetes, and cigarettes. There's a calculator out there that's based on the Framingham Heart Study, and it basically assigns a risk coefficient to each of these. And high blood pressure is probably the highest, cigarettes coming next, and then diabetes coming next as maybe a 2.5-fold risk for stroke going forward. Whereas, hyperlipidemia, we're less than than one in terms of increasing that risk. So a much lesser impact for even dietary and physical activity modifications. But the big three are high blood pressure, diabetes, and cigarette smoking. We don't know about vaping yet, but I still tell them to quit. Non-modifiable risk factors. Those are most things we're aware of. I would be aware of just hypercoagulable states. So especially stroke in a young person, you know, is there a hidden malignancy? Do they have a genetic hypercoagulable state? Are they on estrogen of some kind? You know, sickle cell disease. You know, those are things that we need to be aware of, and usually are something we can do something about. So dual antiplatelet therapy, that's kind of something that's come into vogue the last few years. And basically the antiplatelet agents that are out there are aspirin, Plavix, or probably something you guys haven't heard of, which is Agrinox or aspirin dipyridamole. It's all acceptable, although Agrinox causes headaches and it probably doesn't have a lot of benefit over the other two. So for all intents and purposes, we don't use that. Silostazol or Platol is another antiplatelet agent that can be used for patients who cannot tolerate the others. And there really is no benefit to using a higher dose aspirin. We get a lot of questions, you know, should you be on 81? Should you be on 325? If you're on 81, does it do any good to increase to 325? And the answer is probably no. It probably doesn't make a difference. The official guidelines from the American Heart and Stroke Association are either 81 to 325, but there's really no benefit to the higher dosages and maybe a little increased risk of bleeding complications. And then long-term dual antiplatelet therapy outside of the first 21 days is pretty much not going to get you any benefit. So all we're going to see is more bleeding complications after that acute time period. What we run into often is that you may have somebody with atrial fibrillation, they're on their Eliquis or Xarelto, and then they have a small vessel infarction, and they often do. They may have heart disease, they may have diabetes. And there is some studies that would support that low dose aspirin and your oral anticoagulant are reasonable to do. So there's plenty of folks will have on both, and that really doesn't increase the risk of bleeding complications significantly. Prevention, again, it's, you know, permissive hypertension, but outside the first 48 hours, then we want to be aggressive with blood pressure. New regulations are less than 130 over 80. If we've got blood pressure that we've got a lot of work to do, meaning it's more than 20 points above our goal, then combination therapy is good. The medicines that work better will be the calcium channel blockers and ACE inhibitors based on studies. Diuretics have also been shown to be positive, but beta blockers have not really shown to be a benefit, at least in terms of stroke recurrence. So that probably wouldn't be your first choice, although a lot of folks are going to be on a beta blocker for other reasons. And then this graphic is just to emphasize that the lower we go with the blood pressure, the more benefit we're going to get in mortality over time. Okay. And we're also going to see that benefit be a lot more robust in the younger subset, the 50 to 59-year-old group, rather than the 80 to 89-year-old group. But we're seeing benefits all the way down into the systolics of less than 120. So, you know, without causing side effects or problems, we really should be shooting for a fairly aggressive blood pressure reduction, definitely less than 130. Secondary prevention for hyperlipidemia. The point is here that there is benefit. There are studies that show that if we can get that LDL less than 70, we're going to reduce their risk for both heart disease, TIA, and stroke. And it took us a while to figure that out or prove that. The 2006 Sparkle study was the one that did show a reduction in stroke. Although if you notice, it's, again, a very modest reduction. We're talking 2% absolute risk reduction. And while it's something that is standard approach and is supported by the evidence, again, if someone has a statin intolerance or whatever, again, I don't think we're losing a lot of ground by avoiding that. We all know how we can modify risk factors. Obviously, diabetes is a big one, but don't forget about excessive alcohol consumption. So, what is excessive alcohol? That's always a judgment. Anybody who says, yeah, I have about 3 or 4 a day, they're drinking too much, right? So it's like nobody drinks 3 or 4 drinks every day, just for social reasons. So 1 or 2 a day maybe, but you really want to avoid the daily alcohol use if we can. So, and get that daily use below 1 or 2 beverages. The other thing is people have recurrent strokes on their aspirin or on their Plavix. And then the next question is, well, let's just put them on warfarin, or let's put them on Eliquis because, well, we got to do something. But there's been several studies that have shown that there really isn't any benefit to putting someone on a anticoagulant to benefit small vessel stroke, okay, or atherosclerotic large vessel stroke. Even in patients who had intracranial stenosis, which we know are causing recurrent strokes, they did no better on warfarin than they did on aspirin. And then this gets back to the dissection issue, and are patients going to be better off going on anticoagulation versus just aspirin? And really, a lot of the studies, it's gone back and forth. There may be marginal benefit, or the CATIS study was one that was done about 10 years ago, and that really showed no benefit over aspirin to do warfarin. But in this subset, and this is it was a good study, the TREAT-CAD study in 2021. They looked at patients that were randomized to aspirin or warfarin within 2 weeks of their dissection. And they really did see a benefit. Again, these are a small number of patients. So if you look at the patients who actually had a stroke after their dissection, it was only 7 out of 194. So out of all the dissections, we're only looking at 3 or 4% that actually had a stroke. However, if you were on aspirin, you had an 8% risk. And if you were on warfarin, you had a 0% risk. And therefore, there's a reduction. Now, at the same time, there was 1 hemorrhage in this study. But we're dealing with small numbers. So it's very hard to extrapolate exactly what that risk are we going to, and the hemorrhages are, of course, more catastrophic than the recurrent strokes typically. But again, the good news is that most of these patients are going to do well regardless. But I think for the way we've practiced, and the vascular surgeons the same way, doing anticoagulation for the first 3 months in someone that looks like they have a relatively high risk situation is very reasonable. And that's probably our standard. Last point is on Brilinta. There's been some studies that have suggested that it may have a role in secondary prevention, especially in regards to dual antiplatelet therapy. So the question is, will it be a little better than Plavix if we add this to aspirin? And basically, there's some modest indications that we could see some benefit. They found a subset of patients who had a intracranial stenosis that was symptomatic, and people did a little better on ticagrelor versus the Plavix when you combine it with aspirin. But we also saw a little more hemorrhage, although the overall statistics suggested a benefit. It's certainly not going to be good after the first 21 days. So after that, the risk goes up. And you also want to make sure you're using a low dose of aspirin. One of the subsets, though, is this the sort of the CYP to C19 alleles. And those are the patients who are genetically resistant to the effects of Plavix. And that's about 20% of the general population, which that's a good chunk. If you think of 1 out of every 5 patients you're putting on Plavix, it's not going to do anything for them. We do have some genetic testing, but it's not really shown that we will really make a difference by testing everybody for that. There may be some high-risk people we'll look at who've had recurrent events. But keep in mind that the Eastern Asian population, the presence of this allele is probably 40%. So those are folks that, well, maybe they would benefit from either the Brilinta or the Platol as far as replacing Plavix in those folks. And there's a whole other controversy on aspirin resistance, which has not been borne out very well, but that's going to affect a very small portion of the population. And that, I think, is it. But I'll open it up for questions if anybody has any. So the question was basically, and especially in the older population, at what point do you start to think about whether or not anticoagulation may be more risk than benefit? And especially if they're prone to falls, for example. There was a study some time ago that really clarified that the risk of falling and having a major hemorrhage is really maybe less than we thought it was, and that the risk of stroke is pretty high. So if someone isn't extremely high risk for falls, usually we would say err on the side of anticoagulating those folks, and that's in part because atrial fibrillation has a high risk of recurrent stroke. Whereas, we could make a counter argument for, do we really need to be on a statin when we're 93? And again, you won't find a guideline that says that we should take them off at that point, but the benefit is negligible at that point. Or how aggressive do we need to be with blood pressure? That diagram that looked at the benefits of blood pressure, that's over 10 years, and so if our life expectancy for whatever reason, may not be age, it could be other comorbidities, is a couple of years or 5 years on average, I think it's very reasonable to kind of take the less is more approach sometimes, especially because there can be complications with your statins or some bleeding complications with your antiplatelet agents.
Have you ever had aspirin preventatively, knowing that there's several risk factors?
Yeah, it's a good question, because and an example I run into is, like, we do a scan on somebody for other reasons, and the MRI shows clear small vessel disease that looks like it's premature. But the studies that have looked at primary prevention for aspirin in terms of preventing stroke have really not shown a lot of benefit. And I think this goes, and this is, some of it's fairly recent. And so even with heart disease to a degree, if you have a lot of risk factors and family history and other things, then it's a judgment call, but there's probably some benefit there. But for the most part, the benefit is really modest. And so we're, maybe more so than we did in the past, kind of avoiding automatically putting somebody on aspirin. And every 10 years, it seems like the recommendations changed. And a while ago, it was like, well, it benefits, your colorectal cancer risk. So let's, maybe that offsets. And then, something comes up, but the benefit is really modest, I guess, is the thing we probably do know. And I think there's those patients where we know, or they look like they've had high risk, or I've seen previous stroke, and, and at that point it's reasonable. But if you just see indications of small vessel disease and they haven't had a stroke, for the most part, we'd probably avoid doing it unless there was a more convincing reason. The question is, do the permissive hypertension guidelines change after they've had TPA? And yeah, certainly they do. So at that point, we're looking to keep blood pressures less than 185 over 100 or 180 over 100. So we have kind of a standard post thrombolytic protocol. So automatically and in fact, we want the blood pressure to be lower before we give TPA. So if you have blood pressures that are not coming down below 185, then you technically are a contraindication to TPA. So that changes the ballgame entirely. But we'll still let it go up to 180 if it needs to. And so we'll only treat it if it exceeds that parameter. Question was, if someone's actually running low after their stroke, and maybe they're in the under 100 systolic range, and then from a therapist standpoint, are they safe to get up? And I'd say it's a judgment call. It depends a little bit on the mechanism of the stroke. If it's a cardioembolic stroke, oftentimes the blood pressure doesn't react near as much. If it's a small vessel stroke, then usually we'll see, again, we got a patient that used to be in hypertensive, and we've got lots of small vessel disease, and so the reactive hypertension is a lot more dramatic. So usually you can be pretty comfortable that if the patient's blood pressure is not reacting and going high and they're not getting lightheaded from standing up, we don't typically have to treat it or avoid activity or mobility early. But honestly, it's really a judgment call. There were some studies that looked at, what if we do have somebody that's had a stroke and maybe for other reasons their blood pressure is low and we know it would be better to be high. There's not really a benefit in applying pressors or using pharmacotherapy to do it, but fluid boluses and more bed rest and less activity. So I think it's a judgment call. Hopefully you can just lean on your friendly neurologist to say, is it okay to get them up and that sort of thing. But I think it's a good awareness to have as far as whether someone might be relatively hypotensive, because especially with the small vessel ones, we definitely can acutely worsen those strokes if we get hypotensive.
Do you ever look at math over blood pressure, or are you strictly looking at blood pressure?
Usually not, because it's too hard for my brain to calculate the math when I'm just looking at the blood pressure. But yeah, obviously there's guidelines that are available, but typically, yeah, and again, you'd say, well, and especially, everybody that's 220 over 120, somebody's baseline, maybe they live at 180 and other patients don't. And so, you really would like to cater that, but there's not really a good guideline or a map parameter that we can go by. We'll kind of just let the brain do what it wants in terms of auto regulation and try not to interfere. And then unless we really see it go way too high or maybe way too low, and then we can jump in.
Have you guys considered hypothermia therapy, similar to cardiac, for neurological injuries to reduce swelling from ischemic attacks?
Good question. Maybe we should do a study, but I'm not aware that we've really looked at that. It would probably only be appropriate for a massive stroke with a lot of edema, because a lot of times you're not going to have enough edema to really play a role. And again, patients are conscious, so you're going to have to decide to sedate them and then make them cold. But in patients that have had really catastrophic strokes, there is some thought that, especially when we're trying to consider a hemispherectomy in a young person with a big stroke, that some relative hypothermia might be beneficial. But I'd have to look into that to see if that's kind of gotten legs to it in recent years. So with the cervical artery dissection, would you expect to see different symptoms than maybe a typical stroke? And obviously you're going to have symptoms referable to either the carotid or the vertebral artery. So usually it's a large artery kind of presentation. So some weakness, some numbness, maybe language if it's on the right side. With the vertebral arteries, you're going to typically get more vertigo and ataxia, but you could get double vision and slurred speech. And so you'll get kind of a posterior circulation or brainstem presentation. So you're in that time frame. If you're lucky, you'll have a complaint of neck pain, which may tip you off. So those are the symptoms. But you're typically not going to get a small vessel, isolated numbness on one side. But and then honestly, you tend to see younger patients, and they tend not to have symptoms at all most of the time, even though they've completely occluded their carotid sometimes. And so it can be variable, but you still look for that large vessel kind of presentation. And it can stutter a little bit. So sometimes patients with the dissections will have some variability where it comes and goes over the course of the day.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.